Hey everyone, Ryan here. This video is on a topic that many of you have been asking for. So some exciting things were happening at the Euro Perio9 conference in June of 2018. The American Academy of Periodontology, or the AAP, officially announced a new periodontal classification system, and the guidelines had previously not been updated since 1999, so this is a pretty big deal. Additionally, the Integrated National Board Dental Exam is exclusively using this new classification system, so I'm here to cover it for you and help you feel comfortable using it to diagnose patient cases. So let's look at a brief history of periodontal classifications. In the mid-1970s, we started with chronic marginal versus juvenile periodontitis. In the mid-1980s, that's changed to adult and juvenile periodontitis. And then shortly after, they added in more specific categories, like type N through type 5. In the late 1990s, they introduced chronic and aggressive periodontitis, which we've used for roughly 2 decades, and then announced in 2017 and implemented in 2018, the staging and grading system is the newest one we have and the one we'll spend the most time on in this video. So the major changes implemented at this conference is that there are now 4 main categories of disease processes. These are periodontal health and gingival diseases and conditions, periodontitis, Peri-Implant diseases and conditions, and periodontal manifestation of systemic diseases and developmental and acquired conditions. Now we're going to focus on the first 3 in this video in that order. So we start with periodontal health. Now if things get worse, that turns to gingivitis, and if things get worse still, that turns to periodontitis. Now periodontal health and gingival diseases only includes these first 2, so let's focus on those to start with. The case definition of periodontal health is healthy, soft, and hard tissue surrounding the teeth. That being said, some amount of inflammation is acceptable because, let's face it, no one's perfect. So localized, minimal, and delayed bleeding on probing at isolated sites is hard to avoid and may fall within the spectrum of clinical health. Now, that could be minimal bleeding on probing at less than 10% of sites and probing depths at 3 millimeters or below. These things describe maybe 1 or 2 sites with some evidence of clinical inflammation, but generally, overall, this is a situation of health. Now, this can happen on either an intact or a reduced periodontium, so let's define those real quick. An intact periodontium is one with no loss of periodontal tissue. A reduced periodontium is a periodontium with pre-existing loss of periodontal tissue, but, and this is important, is not currently undergoing loss of bone or connective tissue. So reduced periodontium could be the result of hard toothbrush scrubbing leading to gingival recession, or crown lengthening performed by a dentist. And in these cases, the patient could have no periodontitis history at all. These are things that were involving toothbrush scrubbing and crown lengthening performed by the dentist. So that patient may have a reduced periodontium and they never had periodontal disease at all. In this case, those types of patients that fall in this category have no increased risk of periodontitis. But reduced periodontium could also be the result of previous periodontitis that caused the clinical attachment loss. But now the condition is currently stable because we're in a situation of periodontal health. And by the way, periodontal stability is characterized by successful treatment through control of local and systemic risk factors, resulting in bleeding on probing at less than 10% of sites, and probing depths at 3 millimeters or below, and there's no progressive periodontal destruction. So reduced periodontium, intact periodontium, both of those situations could be the result of, or could be included in this realm of periodontal health. Now, the case definition of gingivitis is clinical evidence of inflammation, and this involves things like erythema, redness, edema, this is localized swelling, and bleeding on probing. So now we have bleeding on probing at greater than or equal to 10% of sites, but those probing depths are still pretty controlled at 3 millimeters or below. Stable periodontium. Again, we're not seeing the progressive loss of alveolar bone and clinical attachment. This is defined as gingivitis. We're mostly focusing on the big change here is this part right here. Bleeding on probing and these clinical signs of inflammation that are occurring at more than just 1 or 2 sites. Now it's either localized to the anterior region of the mouth or the posterior region of the mouth, or it's generalized to the entire mouth. Okay, so now let's move to periodontitis. So periodontitis is defined as the loss of periodontal tissue support due to microbially associated host-mediated inflammation. Now we're talking about deeper probing depths, and we're also talking about the presence of interproximal attachment loss. So much of this is the same that we've known before. Without plaque, there is no disease. Plaque induces an inflammatory response, and the body runs away as the bone and soft tissue attachment retreats away from that plaque. It's evaluated through the clinical attachment, or the clinical evaluation, I should say, of attachment levels or the radiographic assessment of bone levels. And the key here is interproximal. Interproximal, that's an important word in this definition. So we're not talking so much about straight facial and straight lingual. We're focusing more on the attachment loss in the mesial and distal areas between the teeth. Okay, so for periodontitis classification, the new additions are staging and grading. So let's look at staging first. The stage is determined by the severity and the extent of disease at presentation. So this is a static measurement. At this moment in time, what is that patient's presentation? And we'll look at things like severity, complexity, and extent and distribution, and how all three of these work together to determine your stage. Now, staging intends to classify the patient's disease based on the measurable amount of destroyed and or damaged tissue as the result of periodontitis, and to assess the specific factors that may attribute to the complexity of long-term case management. Staging is measured from 1 to 4. That's from slight to severe. So the first thing you look at to determine staging is severity, and severity is primarily based on interdental clinical attachment loss, or CAL. CAL is measured from the CEJ, that's the cemento enamel junction, to the base of the pocket. And your worst interproximal CAL, that's the biggest number, the greatest loss of attachment you have in the mouth, gives you your baseline stage. And again, this is not straight facial or straight lingual. We're talking about the areas in between the teeth. So if that worst interdental CAL is 1 or 2 millimeters, that defines a stage 1, 3 or 4, that's a stage 2. If it's 5 or more, then we're automatically in stage 3 or stage 4 territory. If clinical attachment loss is not available, radiographic bone loss can be used as the proxy instead. And tooth loss due to periodontitis can shift the stage to a higher level. If that patient's lost a certain amount of teeth, we could bump up a stage 1 or stage 2 to a stage 3 or stage 4. And we'll talk more about those specifics when we get to specific examples. Complexity is primarily based on local factors like probing depth, the nature of the bone loss, if it's horizontal or vertical, if there's furcation involvement, if there's occlusal trauma, and bite collapse, just to name a few. And one or more of these complexity factors can shift the stage to a higher level. For example, if your largest probing pocket depth is 5 millimeters, it can upgrade a stage 1 to a stage 2. Or if you have probing pocket depths above 6 millimeters with furcation involvement, you can upgrade that to a stage 3. And if you have secondary occlusal trauma and bite collapse, you could maybe even upgrade that patient to a stage 4. So that's how complexity factors can work. There are also some special factors to consider. If you have vertical bone loss at 3 millimeters or more, that puts them at an automatic stage 3 or 4. Furcation involvement, class 2 or class 3. Class 2 means you have a horizontal furcation that's greater than 3 millimeters. Class 3 means that you have a through and through furcation involvement, so you can pass that neighbor's probe all the way through the furcation area. That's an automatic stage 3 or 4 as well. And if the patient has less than 20 teeth remaining, they're an automatic stage 4. And the last thing that goes into staging is extent and distribution. And this is based on the percentage of teeth that are involved in that severity or complexity. So if the patient has a localized extent and distribution, that means that less than 30% of their teeth are involved in that severity or complexity. Generalized means that 30% or more of their teeth are involved at that severity. And a molar incisor pattern is a very specific pattern where only incisors and molars are included. And this is kind of our classic localized aggressive periodontitis. So to put this in a little bit a more relevant perspective, if a patient has 32 teeth, that's all their teeth, including their wisdom teeth, then this 30% threshold is 10 teeth. So the cutoff for becoming generalized is 10 teeth being affected. If the patient had their wisdom teeth removed and they have 28 teeth, then this 30% threshold is at 8 teeth. So the cutoff for becoming generalized would be if 8 teeth were affected. And again, if molars and incisors are exclusively involved, we don't call it localized, we call it a molar incisor pattern to be even more specific. So, and since there's no longer aggressive periodontitis, that's no longer a thing after this new classification system was announced, we call it molar incisor. So you take one of these three and add it to the stage as a descriptor. So you could call it localized stage 3 or molar incisor stage 4, for example. So to put it all together, you start with the most severe interdental cal and select the appropriate stage. If cal is not available, you do the same thing with radiographic bone loss. Then you look at the teeth lost due to periodontitis. If 4 or less, then you upgrade to stage 3. If 5 or more, you upgrade to stage 4. And then you look at the local complexity factors. So if there are factors that are appropriate to a patient, like vertical bone loss greater than 3 millimeters or less than 20 remaining teeth, you would upgrade to the appropriate stage. Stage 1 is slight severity, stage 2 is moderate, stage 3 and stage 4 are severe. And remember, there can only be one stage per patient, so use the most severe one. All right, now let's talk about the grade. So the grade is determined by the rate of disease progression, the responsiveness to therapy, and their overall assessment of risk. So this is based on longitudinal observation, the assessment of bone loss over time, and other risk factors like smoking and diabetes. So grading is a dynamic measurement, how things are changing over time. And it aims to indicate the rate of periodontitis progression, the responsiveness to their therapy, and potential impact on their systemic health. So this one is measured from A to C, from slow to rapid. Now, thankfully, grading is a bit more straightforward, and clinicians should initially assume a grade of B, and then look for specific evidence to shift to either grade A or grade C. And just like in staging, the first row here is the most important. So we look at how interdental cal or radiographic bone loss is changing over a period of 5 years. And so if it's more loss of attachment or bone loss or bone levels over this period of 5 years, we're favoring more towards a rapid disease progression. If there's not as much loss, we're more towards a slow rate of progression. Secondarily, we can look at percent of radiographic bone loss compared to age. So this would be like if you had a 50% bone loss for a 50-year-old patient. That would be a ratio of 50 to 50, which would be 1. And a ratio of 1 would put you in grade B. Now, if you had 50% bone loss for a 25-year-old, that would be a ratio of 2 and put you at grade C. The case phenotype is talking about if the amount of plaque you see is consistent with the level of disease. So heavy biofilm deposits with low levels of destruction would be a grade A situation. If the destruction is consistent with the biofilm deposits, that would be grade B. And if the destruction you see exceeds the expectations given those biofilm deposits, that's suggestive of periods of rapid progression and or early onset disease. That would put you at a grade C situation. For smoking, the more smoking you do, the more uncontrolled your diabetes is. Those things are going to make the disease progress more rapidly. And CRP stands for C-reactive protein. An elevated serum C-reactive protein is a systemic marker of inflammation and a documented risk factor for cardiovascular disease in otherwise healthy people. So the more CRP you have means you're at higher risk of a faster progressing disease. So grade A is slow, grade B is moderate, grade C is rapid. And just like with staging, you only give 1 grade per patient. But since it's dynamic, the grade might change over time as risk factors are modified. And the idea is to predict future progression based on past progression in the presence of these risk factors. So some other considerations: a periodontitis patient is a periodontitis patient for life, and patients should not return to the level of evaluation and maintenance identical to a patient who has never had periodontitis. So for someone who hasn't had periodontitis, they get an annual or twice a year exam and cleaning. For a patient who has periodontitis, they should always be treated with a certain level of scrutiny and maintenance in order that they don't relapse into a stage of progressive bone loss and connective tissue loss. And despite substantial research on aggressive periodontitis since that last 1999 workshop, there's currently insufficient evidence to consider aggressive and chronic periodontitis as 2 pathophysiologically distinct diseases. So that distinction is no more. All right, so let's have some fun and go over some cases. Now, I designed this patient box to mimic what you'll see on the integrated board exam. So this could be part of a question prompt that you get. So for this case number 1, we have a male who's 50 years old. Their chief complaint is, I'm concerned about some of my front teeth that drift around. They smoke a half pack of cigarettes every day. They have minimal biofilm deposits, interdental cal that ranges from 2 to 8 millimeters, and 14 teeth have interdental cal that's greater than or equal to 5 millimeters. And then we have some clinical photos and a full mouth series of x-rays. So with all of this information that we're given, we know this patient has some kind of periodontitis. So let's start with staging. The most severe interdental cal is 8. So this is greater than or equal to 5 millimeters. So we're automatically at a stage 3 or stage 4. We can see a couple areas where the radiographic bone loss is extending to the middle, certainly beyond the middle third of the root, and this confirms this severity of stage 3 or stage 4. Now his anterior teeth, he talks about this in his CC, the anterior teeth are moving and drifting around, and that's an important statement. You can maybe see his upper left incisor, and these two upper left incisors are flaring out and forward, which is another sign of occlusal dysfunction secondary to a periodontal problem. So that's going to bump us up to more of a stage 4 situation. And since 14 teeth are affected by this level of severity, that's more than 30%. That's higher than our threshold of 30%. So this is a generalized situation. Now for grading, we look at the rate of progression over time, which we don't have in this case. So the next thing we have to go on is the ratio of bone loss to age. And at our worst sites, we're probably at something like 70-75% bone loss, and so it might be even worse in the lower anterior. So 75 is more than his age of 50, so our ratio is over 1, which would favor grade C. We also note that there's minimal plaque, which is inconsistent with our state of disease, which is fairly severe, so that also favors a grade C. And he's smoking a half pack of cigarettes per day. A pack of cigarettes contains 20, so he's smoking 10 per day, which also puts him in that grade C. So let's review all of our findings we just talked about. Here's what we have for our staging. Here's what we have for our grading. And remember that more than 30% of teeth were affected by this severity. So we would diagnose this patient with generalized stage 4 grade C periodontitis. All right, case number 2. Now this time we're given a periodontal chart so we can analyze the clinical attachment loss ourselves. Now, of course, if you want to, you can pause the video and work through these diagnoses by yourself first. Otherwise, I'll keep going and review these so we can go through them. Now, if we do a quick scan, the worst interdental clinical attachment loss, which is located in these 4 rows, appears to be 8. There's an 8 there, and there's an 8 there. So that automatically will put us at a stage 3 or stage 4. Now the plus actually means that it's 10 or more, but we don't count this one because it's not interdental. So again, we look for how many teeth have an interdental cal that's 5 millimeters or more to determine the extent and a distribution of the disease. So we see an 8 and a 6 and a 5. We have a 4 on this premolar. We have, let's see, a 5 that's not interdental, but we have a 4 on that premolar as well. Have a couple of 4s, 3s, some 6s down here, a 5 and an 8 by these molars. Looks like mostly molars are being affected here, and the incisors they do have some cal at 2 and 3, but they're not at that same severity. So I don't feel comfortable calling this a molar incisor pattern because it's really just molars that are affected. So this is definitely going to be considered a localized disease process. Those 5 millimeter or more cal numbers are all occurring by the molars. Okay, now we look for some other clues. And we don't have any clinical photos or x-rays this time, so we really have to rely on the information presented in the patient box. We see that she's an ex-smoker with a 10-pack year history. 1 pack year means that she has smoked 1 pack a day for 1 year. So 10 pack years means she smoked 1 pack a day for 10 years. Or she smoked a half pack a day for 20 years. Or she smoked 2 packs a day for 5 years. Any multiple of that, any equivalent of that could be possible. But the important thing is she's not smoking currently. And she's also not a diabetic, and she has heavy plaque that's maybe not quite indicative of the destruction that she has here in general. So all those things considered, we go to our summary, and so she has things that are more in line with a stage 3 situation rather than a stage 4. She's more in line with a grade A situation, and we said that it was a localized. So we would call her a localized stage 3 grade A periodontitis patient. All right, case number 3. So there's no clinical attachment loss measured this time, so we need to go to the radiographs. Now we notice some things might stick out. This vertical bone loss distal to tooth number 28. There's some mesial and distal bone loss to tooth number 3, some on 4. 8 has a significant bony defect. And since premolars are involved here, we can't call this molar incisor pattern, but this would be a localized pattern because less than 30% of the teeth are affected to that level of severity. The bone loss at these sites is probably at worst about maybe 40 or 50%, so that'll put us automatically at a stage 3 or stage 4. This patient only lost one tooth to periodontitis, that's tooth number 25, which favors stage 3. There's no mention of masticatory dysfunction or occlusal trauma or drifting or flaring. That occlusion actually looks quite nice. So we're pretty comfortably in a stage 3 situation here. The 40 to 50% bone loss with age 60 puts us at a ratio slightly below 1, so that looks like a grade B. And we have no other indicating factors listed here. And remember, we always assume grade B unless we have sufficient evidence to change to A or C. So in this case, we don't, so we'll keep it at a grade B. So this patient is a localized stage 3, grade B periodontitis. Okay, and I have one more case for you guys, case number 4, and a few things about this one should stick out right away. No pun intended. Her chief complaint is the first thing we look at, the gap between her two front teeth, and that those two front teeth are starting to get loose. And now, why might that be? Well, if you look at the clinical photos, you can appreciate how it's subtle, but there's some separation of those back teeth, and these front teeth are banging together, and there's undoubtedly some heavy contact on those incisors. And secondary occlusal trauma means that there's force on the teeth that usually they could handle, but in the presence of periodontal attachment loss, it becomes traumatic. And there's some good evidence for that happening here in this case. There's some significant bone loss, mostly by the upper incisors, and this lower molar for sure. They had to take vertical bite wings just to capture how significant that bone loss was. So this patient describes a molar incisor pattern. We have bone loss at the incisors and the molars exclusively. And I would classify this as stage 4 because of how significant that radiographic bone loss is. Again, we don't have clinical attachment to go off of, so we have to use bone loss on the radiographs as a stand-in or proxy. As for her grading, she smokes less than 10 cigarettes a day, so that favors grade B. But she has uncontrolled diabetes because her HbA1c is above 7%. And just look at how much bone loss she has, and look at her age. She's only 35 years old, so this is for sure more than 35% bone loss. So that radiographic bone loss to age ratio is greater than 1 in this case. So between the uncontrolled diabetes and the rate of her disease progression, more things are favoring grade C than grade B in this case. So for her, I'd classify it as molar incisor stage 4 grade C periodontitis. And lastly, we have peri-implant diseases that go from Peri-Implant Health to Peri-Implant Mucositis to Peri Implantitis. And risk factors and risk indicators for these disease processes include smoking, diabetes, poor oral hygiene, poor compliance with supportive care, excess cement, lack of keratinized mucosa around the implant, and for peri-implantitis specifically, a history of previous periodontitis around natural teeth. There are also some genetic factors that can play a role in this progression. So peri-implant health involves the absence of visual signs of inflammation and bleeding on probing. Implant assessment should consist of visual evaluation, some probing that should be done at least once per year, evaluation of bleeding on probing, of course, and evaluation of radiographic bone levels compared to a baseline bone level at implant restoration. It's not really possible to define healthy probing depths around implants, but in general, peri-implant probing depths should be less than or equal to 5 millimeters. And this is important, that health is possible around implants with normal or reduced bone support, just like with healthy gingiva on a reduced periodontium, as long as you have an absence of progressive bone loss and no signs of inflammation, you can have peri-implant health. So this is the equivalent to our periodontal health that we saw before. Peri-implant mucositis involves the presence of visual signs of inflammation and bleeding on probing. So these signs are things like swelling and redness that you can see here, increasing probing depths compared to the baseline, and absence of progressive marginal peri-implant bone loss. So basically, this is like gingivitis, but around an implant. And ever since that tooth was extracted, this tissue is no longer called gingiva, it's called mucosa, hence the name peri-implant mucositis rather than peri-implant gingivitis. But you can think of it like gingivitis around an implant. And then the third one was peri-implantitis. This involves the presence of visual signs of inflammation and bleeding on probing. That's the same. Increased probing depths compared to baseline. That's the same. And this is increased at 1 year post-implant restoration compared to whatever the baseline probing depth was. Now, in the absence of a baseline recording, we're looking at probing depths that are 6 millimeters or more, and radiographic evidence of 3 millimeters of bone loss or more. In peri-implantitis, the big differentiating factor from peri-implant mucositis is the presence of progressive marginal peri-implant bone loss. So this is really periodontitis around an implant, because all these things are similar to what we see in a periodontitis situation. We're just talking about around implants instead of around natural teeth. Now, putting it all together, I made this summary slide. The green X's means that you don't have one of these qualities, which is a good thing. The red check means that you do have one of these 4 qualities, which is a bad thing. So from health to mucositis to peri-implantitis. So the big changes for this 2018 AAP new periodontal classification: we have a new classification of periodontitis. That's this multi-dimensional staging and grading that we went over with the definitions and through 4 case examples. We have the consolidation of chronic and aggressive periodontitis into a single category. And we have the addition of these peri-implant diseases and conditions, and the clarification of health and gingivitis on an intact versus a reduced periodontium with or without previous periodontitis history. Alright, so that's it for this video, guys. Thank you so much for watching. Please like this video if you enjoyed it, and subscribe to this channel for more on dentistry. If you're interested in supporting this channel and what I do, please check out my Patreon page. Thank you to all of my patrons here for all of their support. You can unlock extras like access to my video slides to take notes on, and practice questions for the board exams. So go check that out, the link is in the description. Thanks again for watching, everyone, and I'll see you in the next video.